Hello, I'm Sunil Rao, and it's my pleasure to welcome you to this editorial discussion titled, Is Appropriate Use Criteria for Coronary Revascularization Advancing Patient Care? I'm joined by my colleagues, Greg Dehmer, John Spertus, and Manesh Patel, all of whom have been really involved in the architecture of the appropriate use criteria. And so I think this is a very timely discussion. Gentlemen, thanks for joining me for this.
Thank you.
Thanks for having us.
So, Greg, there's been a lot of discussion, arguments, debates about the appropriate use criteria. Give us a little bit of a history lesson. Is this the first time we're living with this? Are interventionalists being singled out? Have other specialties done this before? What's the background?
Well, I think it'd be fair to say cardiology has taken the lead in developing this. There are very few other specialties that have not done what cardiology has done. And the entire cardiology community should be really proud of itself for what has been done with the appropriate use criteria. This has a long history. I mean, of course, everybody's familiar with guidelines. And the guidelines do provide us a great structure, but they are based on solid information. The class 1 are multiple things that we know are correct. Class 3 we know not to do. But there's these large gray areas in the middle. And the appropriate use criteria first are meant to help kind of fill in the gap in some of those areas, which are very common areas in patient care. The revascularization criteria is not the first one that was taken on. This effort, which was started by the ACC, really started with imaging tests because of great concerns that there were too many imaging tests being done. The cost of the imaging tests was really an excessive burden. So it was started first with CT, MR, has progressed to echo. And if you think about that, all of those were really tests. The revascularization criteria were the first criteria that were done for a treatment. So it's been a very important effort.
I might just weigh in to say that one of the early sort of factors that led to the development of the appropriate use criteria was a plea by payers who could not understand the rapid escalating costs of delivering healthcare and of testing and of treatments. And they said, we need to do something, and we can certainly use our administrative data and try and just tag people who are outliers and high volume operators and say they must be doing too many, but that's clearly not the right thing. People with expertise will be doing a lot of procedures, and that would be a very coarse way. So they came through the Medical Directors Institute to the American College of Cardiology and say, if you want to help us, this is a very good common ground for us to work so we can be sure the patients who really need it get it with minimal encumbrances, but that we also take collective responsibility for reducing the escalating costs and burden of this. And so the ACC, to its credit, and all of its partners, SCI and the AHA and STS and others, said, well, we appreciate the opportunity to inform your decision making with clinical insight and reality. And so the appropriate use criteria were an effort to codify that so that we could now really make sure that these decisions about judging the appropriateness of treatment are informed by clinical reality.
I might even say that, and I echo both of their comments, that this started historically in the 90s by radiology, informing people that were referring them imaging procedures. And in fact, as John says, early 2000, mid 2000, some states were having payers say, cardiologists can't do CT, cannot do MRI, because they don't have appropriate use criteria. They don't know when they should be done. And in fact, we wanted to inform practice. And so I think the appropriate use criteria sort of speak to two important things. Guidelines tell us about disease processes. There's a stable angina guideline. There's a heart failure guideline. But there's not many procedural guidelines to say, when is it right to do a stress test? When is it right to do this other test? And in fact, if you look throughout all the guidelines, those procedures like stress tests, non-invasive tests, have a lot of indications, but not a lot of evidence, and that's how the appropriate use criteria started.
I mean, that's really interesting because the background of this, which I think a lot of people probably don't understand, is really an effort by the college, it sounds like, to protect their constituency with respect to not only patient care, but actually reimbursement. And what's interesting about that is that there have been obviously widely publicized cases of what's been called unnecessary stenting. And there's been a little bit of conflation between what's been called inappropriate, according to the AUC, and unnecessary. Manesh, tell us a little bit about the distinction between that terminology, inappropriate, unnecessary. Obviously, inappropriate has become a very loaded term, as has appropriate in the current environment where there's a lot of confusion.
Yeah, I think this is maybe the most important point we have, which is words matter, and we know that, right? And I think I often say to our colleagues when we have this discussion, if the appropriate use criteria did not exist, would these cases of fraud be investigated? Would people accuse us of doing unnecessary stenting? Did Dr. Oz say 50% of stents are unnecessary? Yes, all of those things are occurring. In fact, we have a wonderful publication from NCDR that says only 4% fit in the inappropriate category. Well, the terms are meant to say appropriate is that it's reasonable to do it. It's not mandatory. In fact, appropriate doesn't mean you have to do it. You have a conversation with the patient. Uncertain means that the evidence isn't available to clearly be reasonable, but it may be reasonable. In every document, 13 prefaces we've said should be reimbursed. The college works hard to help the payer community to say, as a population, as a group, these categories should be reimbursed. Inappropriate may not be reasonable in general, and in fact, on a population basis, we want to look at care for patients. Now, we recognize payers may be using those in one specific case, but it's to look at trends and how we provide care for patients. By no means does inappropriate mean fraud or deceit. And in fact, unfortunately, because of these recent cases, there's been a little bit of a confabulation of these terms, and I recognize it's a loaded time for interventionalists, and we all want to do what's right. In fact, we want to. And the term inappropriate is hard for some of these things.
And I'd chime in on the uncertain category has really caused, no pun intended, a lot of uncertainty. And exactly as Manesh said, it means that there's not enough evidence that the technical panel could make a firm judgment. But the other thing about uncertain is, remember that the appropriate use criteria for revascularization are based on 5 pillars of information. And boy, as we were having those Monday night calls where all this was being developed, we talked about how do we organize this. And there's a statement in the 2009, and it's repeated in the update now. And this is really a credit to what our colleagues do each and every day when they have to make clinical decisions. There's about 4,000 different scenarios that could have been developed looking at all sorts of different situations, but if we did that, we would have come up with something as thick as the Chicago phone book, for example, and nobody would be able to use it. So in trying to narrow it down and build it on these 5 pillars, there are things that we just couldn't consider. I'll give you an example. Age. Okay, there's nothing in the appropriate use criteria about the age of the patient, and clearly we would all say that you may treat a 50-year-old man much differently than a 90-year-old man. So there is a lot of uncertainty there, but it was also the desire to not really lasso all of the clinical judgment that our colleagues use in treating patients and try to compress that all into one tight ball.
I might just, Greg's done a really nice job talking about the gap in evidence around uncertain cases, but also for the inappropriates. I think it's really important for the community to recognize that the limitations of the methodology prevent us from articulating every possible case. And so when I've been very involved in developing performance measures, and in performance measures we work very hard to make sure that you can have 100%, that you would always get, if you did the right thing every day on every patient, your score would be 100%. In the appropriate use criteria, we recognize and have written in every paper so far that we don't expect everybody to have 0% inappropriate cases, because there will always be unique extenuating circumstances where any competent cardiologist would say this is the right thing to do. I mean, one could imagine that you have a chronic total occluded mid-LAD, you have a big left dominant system with a diminutive right, and a huge circ with a very proximal high-grade stenosis. And if the majority of the myocardium is served by that artery and there's a very threatening lesion there, any cardiologist seeing that patient would say, okay, this is something that I think there's probably a survival advantage for restoring good durable patency to this lesion, and yet by the appropriate use criteria that would be inappropriate. We expect that to happen. What is not expected is that you would have a 0.5% inappropriate rate, you would have a 1% inappropriate rate, you would have a 2%, and I would have a 14 or 15 or 18% inappropriate rate. One of the 4 of us is not behaving in a way that's consistent, because not all of the unusual cases are going to go to any one specific interventionalist.
I mean, your points are really well taken, John, because some of the fears that are out there is this is Big Brother, George Orwell, 1984, someone telling you exactly what you can and can't do. And one of the interesting discussion points that's been raised is that this AUC doesn't take into account patient preferences. Talk a little bit about that, because the way I read them, there are some patient preferences that are included in the update.
Yeah, it's not. We have a gap in being able to define and document patient preferences. I mean, the methodology of sort of quantifying, is the patient really informed? Do they really understand the risks and the benefits and the advantages of pursuing the therapy? Have they really gotten good quality consent and engaged in shared decision making? We just don't have the ability to capture that, to record that in any really good way. And I think patient preferences are exceedingly important. And I don't think, and I blame myself as one who's been very interested in patient preferences and had the privilege of serving on these panels. We didn't emphasize that even enough in the appropriate use criteria, but the preferences could go either way. I mean, there could be a lot of overuse if we took into account patient preferences, because if they were truly informed, they may really have preferred to have medical therapy alone or bypass surgery. And that's something that I think we have to set as a challenge for ourselves and our community to better engage patients in discussions and to figure out if there's a way that we can reproducibly quantify the quality of those discussions, because in my own anecdotal experience, there's enormous variability from doctor to doctor on how much discussion, how much engagement, how much education they provide to their patients. But we also don't want to measure every single thing a doctor does. I mean, we want to respect autonomy, but to have a clarion call, a wake up for us all to recognize that, we really do owe it to our patients to explain all of the options, the alternatives, and make sure they understand it, especially with treatments like PCI, where we're so dependent on the patient to adhere to dual antiplatelet therapy after treatment that we really do owe it to ourselves and to our patients and to the community at large to make sure they really understand those responsibilities before we treat them.
I think this is an important point, Sunil, because a lot of things I hear is that patient preferences should help here in PCI, and I absolutely agree. To John's point, and I think what's been going on is two groups of people we should stop talking for are the patients and what the surgeons can do. So in the cath lab, we often hear, well, they might not be able to bypass this, or this LAD is small. Well, usually there's not a timeout and a conversation to find out if that's the case. So I would say that's one. The second, from the patient preference perspective, I think a framework for all procedures is, you take the right patient with the right procedure, the right execution, and you get the right outcome. But patients, when you're having this conversation, they're going to always say, well, what do you think, doc? And when they ask you, what do you think, what do you say? You have to base your conversation on the available evidence, the available guidelines, and maybe the available appropriate use criteria, and say, here's what the data would say. Then you hear their preferences. You can't include the preferences in the guidelines or the criteria because they're a myriad of preferences, and if you tried to include those in recommendations, then you wouldn't be looking at the evidence and the best expert opinion. So I see it as patient preferences on top of what you can give them with regards to the best available information.
Trying to include that, in fact, may make it even more cookbook, actually.
Right, because you would say anybody who prefers this has to have this.
Yeah.
And it's important to emphasize, there's been several recent surveys, and the majority of patients actually think having a stent is going to prevent a heart attack. And I think we all know that that is not true. I mean, if you're having a heart attack, having a stent will stop the heart attack. We all agree on that. But you have to correct the patient's understanding of what they think this procedure is going to accomplish. And many times the patients have some misconceptions about what that will do. And I think a lot of what has gone on in the past is the physicians have not really done anything to interrupt that thought process.
The other issue that I think a lot of people are worried about, and there's a lot of hand-wringing about, is from the payer perspective, is AUC being used as a stick rather than a carrot. Greg, talk about that a little bit. Has the landscape of reimbursement changed since the introduction of AUC, and how do physicians deal with that particular aspect of that?
Well, I'm not sure that the landscape has really changed as a result of the AUC. The landscape was changing long before the AUC ever came along. And I mean, we know, for example, that 43 cents out of every dollar spent by Medicare goes to cardiovascular services. Now, it's not all to just PCI, it's all cardiovascular services. We've all seen the headlines about how the Medicare program is running out of money, and then by the time all of us retire here at the table, we aren't going to have the health care benefits that other has. So this landscape and the excessive amount of money that in the U.S. is spent. I mean, the U.S. spends, roughly about $6,000 or $7,000 per capita compared to other countries which have excellent health care and spend $2,000-3,000 per capita. So clearly some reform is necessary, and this all got started well before the AUC came along. It is true that we have been hearing stories, and I'll characterize some of them as horror stories, about how the AUC are being used inappropriately. And this time I do mean inappropriately as opposed to some other thing, where they're being used to adjudicate payments. And in every AUC document that's been written, and it's not even in the fine print up front, it says these documents are not to be used to determine payments. Nevertheless, I mean, insurance companies are trying to cut back on their costs. Everybody's trying to cut back on their costs. So I think it was inevitable that some of this would be going on. We need to kind of steer the ship now in the right direction and get it back on course so these are used for what they were intended to use.
Yeah, I would say it's a system, right? It's a system of measurement and quality improvement. And without question, they're being used for reimbursement decisions. We want to support that they shouldn't be just on a one-case basis and as a system of practice. But clearly, I would say, and what we lose often is, what would happen if there were no AUC? Certainly people would still be doing prior authorization, they'd still be doing RAC audits, and they'd still be coming up with ways to investigate and evaluate our practice. And as a physician and professional group, I think we want to lead the efforts to provide information. They can certainly be made better.
Yeah, I might weigh in and have just a slightly different spin on this. I mean, I think that Medicare has announced in the First Coast system in Florida that they're going to start doing prepayment review before paying for angioplasty based on both the proper triage between inpatient and outpatient status, but also with respect to the appropriateness of the procedure to begin with. They have not declared what they're going to use as the foundation for determining appropriateness. And what I fear is that they won't use our AUC. And if these were ever to be used for payment, what I think would be terrific is that right now payers are using radiation benefit managers, people they pay a lot of money to that suck up a lot of resources in healthcare without contributing to better care for all PCI procedures. And what would be ideal would be to say the only ones that you need to do pre-authorization review are those that would be deemed inappropriate if you're prospectively assessing the appropriate use criteria. Then it's up to the physician to say in only 4% of our cases, this is the extenuating circumstances that leads me to feel that this is in the best interest of patient care, and that would be a much more rational way to go. It would certainly decrease the administrative burden substantially on us as providers so we can devote our attention to caring for our patients. And if there were going to be any application of these in prospective payment reform, that would be, I think, the most practical way, because it really does get rid of a lot of administrative hassle, and we must have a good reason for going ahead and doing the procedure, and justifying that wouldn't be as onerous as having to do it across all procedures or having all of our procedures subjected to some administrative approach for assessing appropriateness.
I will say two things about experience now we've had similar to that. So Wisconsin as a state is using the appropriate use criteria as a group of medical providers, and there's maybe a little bit more a confluence of providers that can do that. And then also, as you guys know, the FOCUS project in Delaware. So in Delaware, there's actually legislation because there's a fairly famous case of someone not getting a nuclear stress test. And so the FOCUS ACC project for using appropriate use criteria is now the standard where all of the cardiologists have no prior authorization for imaging, but they get monthly review. And when they start to go too inappropriate, they start to get some feedback. But it took away all the administrative burden. They vastly like the way of providing care for their patients. What we lack with coronary revascularization is real-time feedback and data collection tools, and obviously we're working on that in many ways.
So we have just a few minutes left, and I want to touch on three big topics before we're done. Greg, there are AUC criteria, there are guidelines. Are we going to get to a point where they're integrated into one kind of big electronic document so that people can sort of learn, sort of one-stop shopping? There seems to be a little bit more focus on AUC now externally rather than the guidelines, which used to be the focus.
That's a great question, Sunil. I'm not sure I know the answer. Because there are two different documents that have two different kinds of flavors and backgrounds. So I think my own answer would be probably not, because of the way that these are all developed. But I'd be interested to see what Manesh.
I'll just quickly say that I think we're trying to coordinate the timing. So for PCI, CABG, and the coronary revascularization, which all came out this year, there certainly was a meeting where all of the multi-vessel revascularization criteria, guidelines for PCI and CABG were in the same group having a conversation. In the future, it'd be awesome to have a wiki doc where you could search everything at once.
John, what can clinicians do in the current environment with respect to how they document their PCIs? What is it that they need to focus on? Obviously, if you've got an electronic health record, that can help, but there are many places, particularly in the community, where people are still handwriting notes, volumes and volumes about how they wired this vessel versus that vessel. What should they focus on now?
Well, first, I think that it is valuable to document why you're doing the procedure. I mean, you really hit on, I think, a key issue, which is that we devote enormous energy and space with very technical details without sometimes in an entire chart ever saying why the patient had the procedure in the first place. And I think we need, with the appropriate use criteria now being in existence, to be much more clear on what the indications were. What was the symptom burden of the patient? What was the ischemic burden and risk? And I think that will go a big step forward. To me, I think the prospective assessment of appropriateness is a very helpful decision support tool. And there are very simple ways to sort of do that. I work with a company, Health Outcome Sciences, that has sort of built that toolkit to be able to do it prospectively in the workflow. Sky is coming out with an Excel spreadsheet that does that. Mark Shelton at Prairie has come up with a very interesting flow chart that just sort of highlights the inappropriates, and if we could do that prospectively, it would help in two ways. First, it might give us some pause before after we do the angiogram, but before we do the angioplasty, figuring out if this really is the right thing or not. Secondly, I think that it would allow us to make sure that the documentation is correct, because if I'm talking to a patient who I believe has class 3 angina and their anginal equivalent is dyspnea, and I'm looking at a prospective assessment, and the nurse has entered some data that says the patient's asymptomatic, it will be immediately obvious to me that there's some error that happened there, and I can correct it right up front and create that greater clarity. So I think clinicians should think about tools and strategies to routinely assess the appropriateness in real time if that can be done, and at the very least need to be much more explicit about why they're doing the procedure in the first place.
Facilitate chart abstraction. So last question, Manesh, before we wrap this up. Everyone's looking forward to the diagnostic cath AUC. That's going to be a big one. It's going to make another huge splash.
Really
we'll probably have to repeat this program after that. Right. My question to you is, do you think it's time to move this AUC educational process upstream from the interventionalist?
Absolutely, and from our imaging days, we know for sure that's the case. In fact, for the diagnostic AUC, we're hoping to have a cath referral form, right? Most of what we hear in the community is, if a patient's sent to me to do a procedure, how do I talk to the referring doc and tell them no, they don't need that? In many ways, most of this is point of order, it's education for the doctors that are really doing it, and many times for us, it's not always just the interventionalists, it's the referring cardiologists and general medicine physicians.
Well, we could probably keep going for another couple of hours, but we do have to wrap up. I want to thank all of you for participating in this really informative discussion. From all of us here at the Heart.org Medscape Studios, thanks for joining us.